This is going to be a session where we're going to talk about diabetic retinopathy. So I've got an eminent list of panelists, and I would like to welcome them to stage. Firstly, I'd like to welcome Dr. Dharmarajan, sir. He's the professor and head of Department of Diabetology in Madras Medical College. He's a graduate from Tanjore Medical College, and he has been working in MMC for quite a long time. He's one of the most well-known faces in Chennai in the field of diabetology. Next slide, please. I would like to then welcome Dr. Periyandava. He's another diabetologist who's working in MMC. He's the associate professor at the Government General Hospital in Chennai. He again needs no introduction. He's one of the most eminent diabetologists in Chennai. He has been a formerly chairman for the Board of Studies for MBBS, member in the Ethics and Disciplinary Committee in the Dr. MGR Medical University in Tamil Nadu. He's a regional faculty for the CCEBDM course held by the Public Health Foundation of India at New Delhi. He has also organized several conferences over the last few years. Next slide, please. I would like to welcome Dr. Manoj Khatri, sir. He is a leading ophthalmologist and vitreoretinal surgeon. He's the founder and managing director of IDOC's Eye Hospital in Chennai. He has been the associate professor of ophthalmology at PIMS in Pondicherry. He is the executive member of Governing Council of Vitreoretinal Society of India. He's published several papers in several journals. He's presented widely, and he's performed live vitreoretinal surgeries at various conferences, both state level and national level. And he's been involved in training several surgeons, both nationally and internationally, and he has been the principal investigator and co-investigator in various drug trials related to ophthalmology. Next slide, please. I would like to welcome Dr. Vasumati Vedantam, madam, as well, please, on stage. She's another very leading ophthalmologist, vitreoretinal surgeon, pediatric retina specialist, and the medical director of Radhatri Netralia. She's more than 50 publications on retina in peer-reviewed journals and authored several chapters in several textbooks. She's received the Hanumanta Reddy and Rakesh Sharma Memorial Award for her best work on pediatric ophthalmology and infections in the eye by the All India Ophthalmological Society. She's delivered 3 orations conferred by IMA, an association of community ophthalmologists of India, for her work in ROP, and she's adjudged very proudly. I can say that she's been adjudged to be one of the top 20 ophthalmologists in India by Ophthalmology World Report. So we have a very eminent panel consisting of 2 diabetologists and 2 ophthalmologists, and we're going to have it as an interactive case discussion along with a brief presentation from me. Dr. Manoj Khatri and Dr. Vasumati madam do have some very interesting slides, and I hopefully think time will actually permit us for them to display those interesting cases and slides. Now, today we're going to briefly actually talk about these 4 important things. Give a brief introduction on what diabetic retinopathy is, what are the risk factors, stages, symptoms, and emergencies, what screening guidelines are available, methods, how to slow down diabetic retinopathy, what investigations are available, what are the medical options, and what are the surgical options. Our panel is actually going to talk about all these in detail. And we will be quizzing them and picking their brains as to what's the latest happening in this field. So briefly, we know that a lot of people are affected with diabetes worldwide, and nearly 1 in 3 people who are living with diabetes do have some form of diabetic retinopathy. So without much ado, we start off with our simple case. He's a 54-year-old gentleman. He's got type 2 diabetes for 8 years, poorly controlled. He's got hypertension for 8 years. His blood pressure is 150/100. He's got microalbuminuria, peripheral nephropathy, and dyslipidemia. So he's got everything almost. Now, he doesn't have any symptoms from the ophthalmology point of view. So my first 3 questions are directed to Dr. Dharmarajan, sir. So what are the risk factors for diabetic retinopathy in this patient?
Good morning, ladies and gentlemen. At the outset, I'd like to thank the organizers for giving me an opportunity to be part of this panel discussion. Of course, the case that is projected in the previous slide is almost a prototype of all the risk factors that the patient can have for developing this dreaded complication of diabetes. when you consider the risk factors for developing diabetic retinopathy in a patient with diabetes, the first and foremost that should come to your mind is maybe the duration of diabetes. The longer the duration of diabetes, the more riskier it is. And number two is, of course, the level of glycemic control the patient had, of course. That can be reflected by various parameters, including A1C and the other parameters which you always do when evaluating a patient with diabetes. And of course, the third one is patients having other comorbid, practices like, yes, especially smoking. Smoking is a very important risk factor for developing diabetic retinopathy and also for the progression of diabetic retinopathy. So smoking and alcohol to a certain extent, but smoking is a very important risk factor. And of course, there are certain genetic factors being genetically prone for the development of retinopathy. And then, of course, pregnancy is one important risk factor. If you can project the previous slide, this patient, of course, had hypertension. That's another important risk factor. The higher the BP, higher the risk of developing diabetic retinopathy, leave alone the changes secondary to hypertension and developing hypertensive changes retinopathy. Hypertension and elevated BP by itself is an independent risk factor for the development of diabetic retinopathy. And of course, microalbuminuria or renal involvement, that also produces so many pathophysiological changes which can contribute to the development of diabetic retinopathy. And of course, dyslipidemia is one more. So these are all, the prototype has projected the risk factors for the development of diabetic retinopathy.
Thank you, sir. So what are the stages in diabetic retinopathy? And what generally are the symptoms and signs we see when patients present?
Talking about these symptoms and signs, usually the standard teaching or the standard thing that we would like to convey to all the practitioners is that usually it is asymptomatic, that diabetic retinopathy, unless we look for it, you don't find it. So patients are usually asymptomatic until the late stages when they develop a severe vision-threatening complication. So something which is innocuous or asymptomatic, when you go and investigate or find out, you find a vision-threatening complication inside. So symptoms, usually there are no symptoms, but then it can happen like some floaters or dots or dark spots or sometimes blurring of vision when the macula is involved. So these could be some of the symptoms of diabetic retinopathy, but never wait for symptoms. Always make it a dictum that the fundus, the retina should be screened during every visit annually.
I think this is the most important point, that we have to acknowledge that they do not have symptoms. Yeah, and that is the important learning point here, sir. Yeah, Thank you, sir.
And of course, the stages, we have various stages. Clinically, we have a preclinical stage where there are no demonstrable signs of diabetic retinopathy, but still pathophysiological changes happen. And then we have early stage, middle stage, and the later advanced stages. Early stage, of course, mild NPDR is one which we call an early stage, which requires only a follow-up. And then middle stages, the moderate or severe or very severe NPDR, all those, they fall in the middle stages. And of course, once the patient develops a PDR, proliferative diabetic retinopathy, goes into advanced or late stages where they can have all the other associated complications of a vision-threatening retinopathy.
And what are the emergencies, sir, that will need urgent review by the ophthalmologist?
As far as the practicing physicians are concerned, yes, you should always remember, whenever a patient has a visual impairment, of course, that could be due to so many reasons. Of course, we have our own limitations while evaluating visual impairment. So whenever the patient has a visual impairment or visual loss, I think it needs an ophthalmology assessment. But then again, for retinopathy, patients with diabetic retinopathy, during the early stages, as long as they have a early NPDR, mild NPDR or moderate NPDR, we can follow up the patients. But then once the patient develops complications, once the macula is involved, maculopathy is a definite indication that requires an ophthalmology referral. Then, of course, once the patient has complications like a retinal detachment or a hemorrhage or a bleed, all of them which can produce impairment of the visual vision, they are all signs where we need to refer to an ophthalmologist for further evaluation and urgent treatment, of course.
Yes, sir. So briefly, to actually summarize what we have been discussing, sir, the risk factors for developing diabetic retinopathy, we all know, are the duration of diabetes, the diabetic control, blood pressure. Dyslipidemia does not seem to influence it much, but this is the evidence which actually just is being displayed, and we've already discussed about this. And we know that there are a number of pathological processes. We're not going to discuss all these in detail. The normal retina becomes very abnormal looking here. And this is the grading of retinopathy which we were discussing, and I'm sure most of you actually already know this: mild, moderate, severe, and proliferative. And untreated retinopathy obviously will lead to vision loss at the end. And just to show you some pictures, this is a normal-looking retina, and this is a very mild retinopathy with, it is non-proliferative. And this is a moderate retinopathy with hard exudates and microaneurysms. And this is severe retinopathy with venous bleeding. It's still non-proliferative, and now we have proliferative retinopathy. And you can see there's new vessels on the disc, and there's cotton wool spots as well. And in the advanced stages, obviously, you have vitreous bleeding and new vessels forming on the iris. And then in the advanced diabetic eye disease, there's retinal detachment. And if it involves the macula, you get macular edema and ischemic maculopathy. And we already discussed that all patients need to be referred to an ophthalmologist, but some patients, as Sir was saying, need urgent referral to the ophthalmologist when they have proliferative disease or vitreal hemorrhages, retinal detachment, or macular edema. Now, next, I think we're going to discuss about how we screen these patients, because that's a challenge I think we face in the community. Sir, this is for Dr. Periyandava, sir. Whom should we screen, sir, and how frequently should we screen these patients?
Actually, according to latest ADA guidelines, 2018 and 2019, and they have 3 sets of people should be screened. Almost all the diabetic patients should be screened. And type 1 diabetics, because the symptoms will start immediately, so they will report to doctors immediately. So we can be a little relaxed. Until before the first 5 years of the duration of diabetes, we have to screen at least once. That is a guideline given. And for all type 2 diabetic patients, because symptoms are very, very silent, yes. Even with the sugar level, we have seen 400 milligrams, 600 milligrams blood sugar level, no symptoms. So all the type 2 diabetic patients should be screened immediately on the first visit itself. And that's something. And third thing, they give importance for the pregnancies. As Professor Dharmarajan said, it's a rapidly progressive. So all the known diabetic patients, whether it's a type 1 or type 2 diabetic patient marching through pregnancy, that is pre-GDM, so they should be even pre-counseled. Even before conception, they should be counseled to whether to screen for any diabetic retinopathy is there or not. So if it is present, even after consumption, it should be monitored very frequently, maybe once in 3 months or once in 3 months, once in 6 months. The pregnant woman should be monitored, and monitored by the specialist, not the ordinary physicians. Okay, that's what the guideline says. And
is this happening, sir, in India or Tamil Nadu?
Yeah, actually, some centers we advise routinely. But because we have large number of diabetic population, diabetic clinics and other things, so the message should go. So I think this sort of discussions will definitely, the message will reach all the treating physicians.
Yes. I understand there are no community screening programs in Tamil Nadu, but there are some screening programs in our neighboring state. Is that correct, sir?
Yeah, yes, sir. Actually, in Tamil Nadu also, in small pockets, actually some NGOs like Lions Club, Rotary Club and other things, they do, but not in large scale, which covers the entire population of Tamil Nadu. But whereas Andhra Pradesh government has taken a very good initiation, I think they have last couple of years back, they have started micro-level primary centers. So the tele-screening programs. So all the diabetic patients, they are screening, and some centers, they analyze all these reports through the internet.
Yes, madam.
In the national level, I'd just like to add that the All India Ophthalmic Society has coordinated with all of us retinologists in consultation with the diabetologists in the pockets, local diabetologists, and it has started a nationwide screening for patients with diabetes to rule out diabetic retinopathy. It's a recent initiative, about 6 months back. Yeah.
And they are collecting a database for this?
Yes, that's right.
Okay. And sir, how do we prevent or slow down diabetic retinopathy? What can diabetologists do to do that?
Actually, almost Dr. Dharmarajan has mentioned about many risk factors. Everything should be covered. The main thing I want to emphasize is 3 points. So one is good glycemic control. So we should target fasting plasma glucose less than 120, postprandial plasma glucose less than 170, and HbA1c If possible, if there is no risk of hypoglycemia, it should be aimed at 6.5. So these targets definitely will prevent progression, as well as we can expect slight regression also. That's number one thing. So good glycemic control, that is number one. And the second thing, as Dr. Dharmarajan said, the hypertension. The hypertension is also a very worst factor which it worsens the diabetic retinopathy. So we have to effectively control the hypertension. And if possible, small dose of diuretic may be added in the routine antihypertensive regime. And the third thing is dyslipidemia. So among the one dyslipidemia drug, that is PPR alpha agonist, that is fibrates. They are documented to give beneficial effect in patients in known diabetic retinopathy. So it should be added when there is diabetic retinopathy. And apart from that, stopping smoking and other things we have to consider.
Yes, sir. So to briefly summarize what we have discussed, yes, as we were discussing, we should screen each trimester in pregnancy. We should screen almost every year if the patients are asymptomatic in people with type 2 diabetes. And type 1 diabetes, we can be relaxed for the first 5 years, but then afterwards, even in normal patients, we have to screen every year. And screening is actually justified because it's an extremely important health problem, and it is quite heartening to know that the All India Ophthalmology Society has taken up this initiative after such a long time, and data is being gathered. Now, the advantage of screening is it's quite simple to actually perform, and it's not that expensive compared to what expense the patient would meet subsequently if they developed diabetic eye disease. And as we were mentioning, once they actually have symptoms, it's going to be in a very advanced stage. And anyone can actually screen, including endocrinologists and general practitioners in the clinic. All we need is a fundoscope or a retinal photograph taking device. And these are all some of the methods we can use in our clinic. Of course, ophthalmologists have access to fluorescent angiography. And as we were discussing, healthy lifestyle, improving glycemic control and blood pressure regulation actually is quite important in regressing and treating diabetic retinopathy. The use of aspirin, megavitamins, and experimental agents like octreotide, protein kinase inhibitors are all still experimental. No major benefit has actually been shown. And there's lots of actually evidence to show that good glycemic control, good blood pressure control actually helps in regression of retinopathy. Now, to take this case further, as is common with our patients, this gentleman does not keep his glucose or blood pressure under control. He does not go for routine eye checkups, and he's now complaining of blurred vision and loss of vision. And he's now got proliferative diabetic retinopathy and macular edema. So we are now finally involving the ophthalmologist because we have forced him. He's got vision problems. So these questions are addressed to Dr. Manoj Khatri, sir. So what are the past and new investigation modalities do we have to identify diabetic retinopathy?
So first of all, as soon as we get this type of patients, as sir has rightly said initially, we also go through a complete systemic evaluation. Then ophthalmic evaluation starts from visual acuity to other checking other ophthalmic parameters. But when we come to the retinal evaluation, two are the most important criteria or the evaluation processes are. One is the photographic documentation of the retinal images, as well as staging based on different investigative modalities. The most common is optical coherence tomography. As you have already mentioned, this patient has proliferative diabetic retinopathy disease, so we are not going to go in for much in favor of an angiography if at all it needed. But it can be an optional tool if you are not able to judge how much of proliferative disease is there. For us, when we come to vision point of view, we start grading this based on these two parameters: visual acuity as well as what changes we see on optical coherence tomography as well as clinically, and then think about treatment. We don't normally now wait for a very, very good systemic control because by the time the disease already progresses to a second stage and when we start losing vision considerably. So the ophthalmic treatment starts consecutively at the same time, yes, hand to hand. And the most common form of treatment right now is something called as antivascular endothelial growth factor therapy, which is in form of injectable medicines into the vitreous cavity. And that goes on over a period of time as and when needed. So once we see these type of patients, it is really, really possible that we can control this for further progression and goes for a stage of detachment, and then you need surgery and also. So it's not that case, end of the problem. We can really get back good quality of vision for these patients.
So how many anti-VEGF agents are available currently?
How many are available?
Yes.
There are 3 different varieties. So one is called as bevacizumab, then we have ranibizumab, and then we have aflibercept. All of them have their own advantages and disadvantages. Also, cost factor, especially in the Indian scenario where we are dealing only with non-insurance market, plays a very important role. So based on patients' pathology, there's, their economic status, then we decide and try to judge at how frequently he'll require treatment, how many sessions of treatment are required. So the basic counseling at the primary, the first setting itself is very, very important for that particular patient. The second thing what I will also like to add on the screening modality what you are talking about, we encourage and request all the diabetologists who are in association with us is like how we are doing all the systemic parameters for that particular patient. You can install one more modality of investigation called as retinal imaging. We have many, low cost screening retinal cameras available nowadays, which can be even non-mediatic. That means you don't have to dilate the patient. It just takes few seconds to take a retinal image, and it can be linked to any ophthalmic center of your choice or your friends. Or you yourself can sometimes try to grade as you have rightly shown. And any diabetic retinopathy change, what you see in that particular patient has to be referred immediately, so that the further grading by a retinologist can be done. And you will be surprised that you can pick up many other ophthalmic diseases, not only retinopathy, if you just have one basic tool, because every diabetic is a risk for developing other type of retinal problems as well. So we can prevent blindness at a very early stage. It's always an inhibition once for the referral. The second is the patient's counseling, because they also tend to not to go from one clinic to other clinic. So that can be one of the very short and sweet alternative.
So is there any role for steroids, intraretinal steroids?
Yes, so intravitreal steroids, again, we do have many types of steroids nowadays to interplay with us. So we, first line is anti-VEGF therapy. If the patient is not fit for anti-VEGF therapy, like if the patient is pregnant, we cannot give them anti-VEGF due to systemic toxicity risk factors. Recent history of MI or stroke, that is again one of the common contraindication, or patients has very high uncontrolled blood pressure. So then we try to go to alternative therapy. There is also a role of steroid as a primary therapy in selected cases as well. So we pick and choose cases, we tailor-made the approach, rather than just saying, okay, patient has this much of retinal thickness, it will benefit with this drug. It's not like that. So you stage the disease, classify the disease, see the patient's need, and then tailor-made the approach and counsel them and go on.
On a head-to-head comparison, sir, how does anti-VEGF agents fare versus steroids?
Anti-VEGFs are the first line of treatment, especially for diabetic macular edema, treatment of diabetic macular edema. Treatment for proliferative diabetic retinopathy disease, laser is the gold standard. That means the retinal laser to be done to the area where there is no oxygen supply. So that is the mainstay of treatment. But if you go for treatment of diabetic macular edema, we always classify into 2 varieties. One is called as tractional and non-tractional. Tractional means something is pulling to the retina. So then we don't go ahead with this kind of vitreous therapies with those kind of patients. We straight away go for surgeries. And if there is a non-tractional diabetic macular edema, definitely anti-VEGF therapy is the gold standard as well.
Gold standard. And are there any future medical options in development currently?
There are lots. We'll have a whole day of session. There's so many research molecules are going on. We are coming with sustained release devices which can be in the eye for about 6 months to a year's time, and many anti-VEGFs are there which can be even more effective. However, all the research is directed towards 2 pathways. One is the VEGF-driven pathway. The second is, as we were listening to the initial talks as well in the morning, inflammation is one of the key factors for diabetes mellitus per se. So that's what our understanding of diabetic retinopathy is also relying on the pathway of inflammation as well. So we are targeting both the pathways now, VEGF-driven as well as on the other side, inflammatory pathway.
Okay, sir. Thank you very much, sir.
Thanks.
Madam, what are the surgical options that are available?
Surgical options is vitrectomy. All of us are aware that vitreous is a transparent jelly-like substance which cushions the retina, which is a light-sensitive layer of our eyes. It is a necessary evil, so to say, in a diabetic patient because most of the pathologies, including diabetic macular edema, as well as the proliferative component which causes bleeding, is initiated and started by the vitreous, which becomes pathologic because it acts like a sink. It takes in all the growth factors and the inflammatory free radicals which are secreted by the diabetic retina, and it holds it like a sink, which alters its biochemistry. So it sort of starts pulling the retina, it starts contracting, it loses its transparency. Any bleeding which happens also accumulates in the vitreous, which is what we call as vitreous hemorrhage, and is seen as floaters or black spots or flashes. So in essence, the surgical management of diabetic retinopathy is vitrectomy. Ectomy means removal. So we go inside, it's a microsurgical technique, and nowadays it can be done without sutures, just like cataract surgery. And we can remove the vitreous gel and the attendant traction. So what happens is, it is a sink which retains all the free radicals and the inflammatory growth factors. So they are also removed. So in essence, the eye is restored to its physiological state. So the main surgical option available at present for treating diabetic retinopathy is vitrectomy. And to a certain extent, even laser is nowadays, many people think of laser also, which is actually the gold standard for treating diabetic retinopathy, and I was asked to talk about laser as well by you. So laser could also be considered as a surgical modality. And for diabetic macular edema, which is water accumulation in the central portion of the retina, we have a gentle laser targeted to the microaneurysms, which is where the fluid starts leaking out. And for the proliferative component, we do what is called pan-retinal photocoagulation, wherein we treat the entire periphery of the retina where the new vessels actually form. So laser, what it does is it thins the retina, so it reduces the demand of the retina for vascular endothelial growth factor of VEGF. And VEGF is the main pathologic agent which drives diabetic retinopathy, and that is the rationale for the use of anti-VEGF injections in the eye also. So, but laser is a more permanent procedure, and it was the gold standard of management of diabetic macular edema till now. Now it's superseded by anti-VEGF injections. But for proliferative diabetic retinopathy with the bleeding, laser continues to be the gold standard for treating.
And any future experimental surgeries which are being developed?
Yes, there is something called robotic vitrectomy, which is being developed, in which vitreoretinal surgeons like us may become obsolete and without work, in which a robo will actually do the vitrectomy. And of course, certain other modifications like the vitreous has to be detached from the retina. It is not necessary that we have to remove the vitreous. So in understanding with the pathogenesis of the diabetic, proliferative diabetic retinopathy, we are also thinking of injecting thromboplasmin into the eye, which will create a physiologic detachment of the vitreous from the retina. So in effect, the tractional component of the vitreous over the retina is removed, as a result of which, the therapeutic results akin to vitrectomy may be achieved.
Thank you, madam. And finally, what are the complications of treating diabetic retinopathy, like the VEGF side effects systemically?
Yes. Now, anti-VEGF injections, of course, have been a game changer, but they are not without risk. The most important thing that we have to understand that VEGF is a very important physiological molecule for the diabetic patients. Especially, it's very important, as you're all aware, that it's important for the formation of collaterals in the myocardium. So when we inject an anti-VEGF agent, especially an agent like bevacizumab, which has got a long systemic half-life, it circulates for almost 20 days in the body, what could theoretically happen is the patient could be at a risk for silent heart attack because the formation of collaterals in the myocardium is impeded. And in fact, routinely, whenever we advise anti-VEGF injections for our patients also, we just make sure that the patient does not have a previous history of stroke or myocardial infarction. And most of the patients who receive anti-VEGF injections are diabetic for quite some time. So it is a risk that we have to explain and take a physician opinion and then inject the anti-VEGF. And it's preferable to inject anti-VEGFs like ranibizumab, which don't have that much a long systemic half-life. It has a systemic half-life of only about 6 hours. So it is a relatively safer agent, and it has got excellent intraretinal penetration, so stays within the retina, so doesn't affect the body that much. So that is one. Plus, any injection, unless we maintain a proper cold chain storage and sterile conditions, can cause a devastating infection within the eye called endophthalmitis. And especially diabetics, because their immunity is compromised. They're basically immunocompromised. So their healing is also impaired, as a result of which they are more prone to the development of this infection. In fact, all over the world, we have several reports of endophthalmitis, and patients have lost their eyes following intravitreal injections. So we have to be quite careful. And if the injection is not given correctly, it can lead to cataract. And you were mentioning about steroids. And steroids have a propensity to increase the cataractogenesis in a diabetic patient. Plus, they are also at risk for developing what is called glaucoma. Just as we have body pressure in the eye, we have high pressures in the body pressure, like hypertension. We have high pressures in the eye, which is called glaucoma. And when we inject a steroid in the eye, those patients can develop glaucoma, as well as increasing a tendency to cataract formation at an earlier age. So
Thank
these
you
are the
very
complications.
much.
Thank you.
Thank you very much, madam. I think we would like to conclude here in the interest of actually time, but we would like to take some questions as well. Yes, please, sir.
I think it's discussed very well, but I would just like to make two comments which are of a clinical relevance. So whenever someone is having a macular edema and receiving pioglitazone as an anti-diabetic management, the pioglitazone should be discontinued.
Yes, sir.
This observation we have also published and already mentioned in the literature is that the pioglitazone should be discontinued in those who have a macular edema. Our preliminary work on macular edema and SGLT2 inhibitors that we are continuing, but data are very encouraging that it reduces, the SGLT2 inhibitors also helps in reducing macular edema. The another point which we have also published in AJO, that was a use of statins in resolving the hard exudates. The hard exudates can be resolved even with statins. So this we published in AJO, and this is a part of an ADA position statement where our reference is quoted that a use of statins can reduce this. And lastly, the lesson which we have learned from our ophthalmologist is that even a patient who is coming with a macular edema, there is no hurry to rush for laser. Even you give a 4 weeks of intensive therapy targeting multiple risk factors, blood pressure control, blood glucose control, and statins, can reduce the demand of laser in 30% of patients. This we published in Diabetes Care last year.
Thank you very much, sir, for your comments. I think we are going to wrap up now. I would like to thank the panelists. It was a very, very interactive and useful discussion, enlightening us.
So we are leading in ophthalmology and diabetology. But unfortunately, the fundal screening in this state is not taken up. If you want, I will become the scapegoat for that, because it's a very good work. People have taken up in GDM, but fundal screening is not taken up in spite of the fact that Andhra Pradesh is playing as a role model.
Thank you very much.
Actually, we've started with the Corporation of Chennai, and it has initiated a program for screening in the urban triangle.
We are far behind. I'm a public health expert. We are far behind. Okay. Sorry.
Thank you very much, sir. Thank you. We are closing the session, sir. Thank you.